How many of you guys remember the days when spinal immobilization consisted of taking every man, woman, child, infant, dog, cat, goldfish, just anybody who was within 50 yards of a fender bender and putting them on a backboard? Yeah? Okay. Right, and it didn't matter if they didn't have any pain in their neck or their back. It didn't matter if they were completely neurologically intact. If you were in that car, you bought yourself a backboard. So that's how we did it for decades. In fact, spinal immobilization really started to come about in pre-hospital medicine back in the 1960s. Lots changed here in recent years, though, for EMS, because now you've got things like spinal clearance protocols. Does anybody have this where you work? Okay, several of you, good. And taking it one step further, every year it seems like there's more and more agencies that are switching to protocols that have basically eliminated the backboard. Anybody have that? Okay, a few. My question to you is, when these changes first started coming out, were any of you skeptical?
Yes.
I know I was. I remember when our medical director came to us and announced these changes, that the backboard was being scratched off the protocol. I thought he was nuts. I thought he'd lost his mind. Now, in fairness, I'm very skeptical by nature. I come from the show me state, okay? So I'm going to blame that. And my philosophy is trust, but verify. So I did what any good skeptic would do. I set out to prove my medical director wrong. And to prove the so-called evidence was flawed. So I read literally hundreds of research documents. Do you know what I found out? That I owed my medical director an apology. Yeah. So today what I'd like to do is to share with you some of my findings. Our goal this morning is going to be to answer the question, does spinal immobilization using the long backboard cause more harm than good? And if so, what are we supposed to do about it? What do we do with these patients? Are there any alternatives that are proven to have better outcomes? And lastly, what does the most recent research say? Does it support the changes that we've made? And are there any other changes coming down the pike? So I'd like to tell you a story. It was Friday the 13th, July 2007. So now I'm not a superstitious man, but if I had known what was in store for me that night, I would have called in sick. At the time, my wife and I had only been married for about 2 years, and she was now 4 months pregnant with our first child. And as a matter of fact, I had received my paramedic license in the mail that very morning. Things were going according to plan. In fact, even better than what I could have hoped for. But, as Murphy's Law states, well, needless to say, Murphy was about to show up. So my partner and I are driving down the highway at about 65 miles an hour, and it's 11:03 p.m., and it's dark, very dark. I'm in the passenger seat, half asleep. We just finished a long-distance transport, and we're on our way back to the base. And it's a very rural area. Nothing but trees and farmland as far as the eye can see. But then, suddenly, my partner breaks the silence, and he says, "Is that a horse?" Last thing I remember is seeing a 2,000-pound horse coming through the windshield right on top of me. Then it was all dark. Next thing I recall is waking up just spitting blood and glass and shrouded in darkness and very confused. And the other thing I started to slowly become aware of was my partner holding my head in line. Now I had no idea where I was, what had happened, and as my partner's explaining to me that we'd been in this accident, I didn't believe him. I thought I was dreaming. Literally, I thought I was dreaming. None of it made any sense. And there was one thing, however, that did not escape my attention for even 1 minute, and that was the pain. My entire left side felt like it was on fire. But what was especially bad was the pain in my wrist. I looked down and it was badly angulated and swollen. I couldn't even tell that I was seated in an ambulance. The cab was so mangled. I was flown to a community hospital where I was told that I had had a concussion as well as several broken bones, including 4 bones in my left wrist and then also my scapula. But that wasn't the end of it. Then they told me that I had also broken my neck. Now, the only thing I remember thinking when they told me that was, that's impossible. My neck doesn't even hurt. But just a little pop quiz question for you. What did I have going on that would have made it where I did not notice any pain in my neck? A distracting injury, exactly. Another blackout, I wake up and there's a nurse practitioner in the room holding a CT film. She holds it up to the light and this is what I see. C5 was shattered. I had what they call a teardrop fracture, and my spinal cord was compressed on one side, bulged on the other. It's literally millimeters away from paralysis. They think that what had happened was as soon as we impacted the horse, it caused that deceleration. I flew forward, tried to protect myself by lifting up my hand. Force impacted my wrist. Wrist impacted the top of my head. Force traveled down the neck, broke the spine. Force continued traveling down and broke my scapula. A lot of force. The teardrop fracture is one of the most unstable fractures that you can have. The reason is that it disrupts what they call the posterior longitudinal ligament. Of all cervical spine fractures, only 15% are teardrop. And 91% of people who have teardrop fractures end up with permanent neurological damage. The good news just kept on coming. I was told that between the damage to my wrist and my neck, that I would never again work as a paramedic. In fact, they told me that the surgery alone was likely to leave me paralyzed from the neck down. Oh, and by the way, this is the one and only picture of me during my stay in the hospital. That's because I specifically told everyone I do not want pictures of this. In what world would I ever want to remember this event? My father-in-law did not get that memo. But it was okay because I was so doped up on Dilaudid, I didn't even know he was in the room when he did this. The surgeon performed an anterior-posterior fusion. I'll just give you a spoil alert looking ahead. I didn't end up paralyzed, and I did go back to work as a paramedic. Okay? I know, you're all shocked. But long story short, I came out of it fine, and in less than 6 months I was back on the truck. So you can understand why I was so biased when the changes in spinal immobilization practices came out. The traditional spinal immobilization, when it first came out, it wasn't because of scientific evidence saying that we needed to do it that way. It just seemed to make sense. You know, you break your arm, you splint it. You break your leg, you splint it. You break your back or your neck, you just splint it, right? But then as EMS started to shift more towards evidence-based medicine, a number of studies started coming out. Someone got the idea, I wonder if this actually does anything. So they started looking at it, and it called into question the efficacy of traditional immobilization. And you see, it all comes down to a question of cost versus benefit. What benefits does spinal immobilization have? Sorry, there are no proven benefits. Of all the research that's been done, There have yet to be proven benefits. When that was announced, I still had to say, wait a minute, absence of proof is not the same thing as proof of absence. Now, in other words, it's possible that the board does have a benefit. We just haven't been able to prove it yet, right? Okay, again, my skeptical nature, that's how I looked at it. And I thought, so big deal. We end up immobilizing a whole lot of people that don't really need it, but what's the harm in continuing to use the board just in case? So I put that question to my medical director, and this was his reply. Because you have to immobilize 392 patients before you get to one who might actually benefit from it. And the board does more harm than good. So that got my attention. I said, whoa, what kind of harm are we talking about here? You know what he said to me? Pain and pressure ulcers. I was not inspired by that answer. And so that's when I set out to do my own research. And here's what I found. Let's start out with penetrating trauma, because this is one of the first things that got removed from immobilization protocols. And by the way, this is Bubba. Bubba's my cousin. I'm from southern Missouri, and you know, everybody in Missouri likes to hunt. And Bubba was out with his brother Daryl. And Daryl mistook him for a deer, shot him in the back of the head. By the way, if you couldn't tell, I'm making a joke. This is not really my cousin. But we'll go with it. So obviously they had to cut that down for transport. And this is what they had to do in order to get the broadhead out of his skull. They just took part of the skull with it. Now, unfortunately, Bubba did experience some permanent brain damage, but being from the Ozarks, nobody could tell. I can say that because I'm from there. Anyway, so you guys remember that penetrating trauma to the neck and torso, that used to buy you a board, right? Why? Yeah, it was by default. We have no idea where that projectile went inside the body. It might have hit the spine 16 times for all we know. So that's why we boarded them. But then researchers examined this, but there was one study that's particularly interesting. They found that you have to backboard 1,032 patients before you get to one with an unstable fracture that might, keyword might, benefit from it. And on the other hand, you only have to backboard 66 before you get to one that you're going to kill by backboarding. Yes, I said kill. You'll understand that here in just a moment. So another study looked at 357 patients with gunshot wounds to the torso, and while almost no one would have benefited from immobilization, 41% there needed intubation, 55% needed immediate surgery, which we can't do in the field just yet. So immobilization means more time on scene, and more time on scene means bad day to have internal bleeding. So that's one of the ways that immobilization was found to be more harm than good. But that's penetrating trauma. What about blunt? What about blunt trauma? Much to my dismay, I discovered that the list of harmful effects is a mile long. Anybody have any just guesses as to some things that the backboard might do that could cause harm? Yes, it does have an effect on breathing. And one part of that is airway control. It makes intubation much more difficult. And as far as breathing goes, what about aspiration? What do we do for patients on a backboard when they start to vomit? Now wait just a second. In decades, since starting immobilizing patients, this was the best idea we could come up with? Innovation at its finest. Yeah, there is no way to do this without causing lateral shifting of the spine. That's been studied as well. And if you strap them down tight enough to hold them from moving much, you've just chosen to restrict chest expansion. And by the way, who here, honestly, has spent 15 minutes on scene padding the voids? Okay, I didn't think so. It increases respiratory effort by as much as 15 to 20% in healthy patients, and it's more pronounced if someone's got pre-existing medical problems and for patients that are over the age of 65. Another thing that it does, the collar increases intracranial pressure, which can be particularly bad if you've got somebody with a head bleed. Now, do patients with spinal trauma sometimes have head injuries along with that? Yeah, right, obviously. So that's a pretty big concern. And then neurological injury. Now wait a minute. This is exactly what the backboard is supposed to prevent. Neurological injury, furthering injury to the spinal cord. So how does that happen? So they did this one study in 1998. Okay, this is how far back we knew there was a problem. Where they looked at a group of patients from the United States as well as a group from Malaysia. 334 from the United States, all of whom were immobilized. 120 from Malaysia, not a single one of them was immobilized. None of the patients in Malaysia were immobilized. And yet, the people in the United States were twice as likely to suffer secondary neurologic injury. So the authors concluded that in their estimation, it was the delay to definitive care that led to these results. Edema, the swelling from the injury around that spinal cord, led to hypoxia to the spinal cord, which furthered the injury. That was what they believed. And this was 1998. So that's neurologic injury, and then lastly, death. That one kind of got my attention. So this is mainly due to delays in transport to definitive care. You see, when people have a mechanism that's strong enough to fracture their spine, there's sometimes some other injuries that go with that. And if you happen to have a lacerated liver or a tension pneumothorax, you might potentially need surgery, which is something we can't do. So if we spend a whole lot of time packaging people on the scene, what you end up with potentially is a well-packaged corpse. So bottom line is, while we couldn't prove any benefits to the backboard, we could prove a whole lot of harmful effects. So traditional spinal mobilization, it doesn't even immobilize. The one thing it's supposed to do, and it fails. Best of intentions, less than impressive results. It's kind of like if you change the oil on your car, you're pouring in the brand new oil, but you forgot to put the drain plug back in first. Same kind of thing. Great try, but you failed. So, now what are we supposed to do? First of all, we need to get rid of this language. Spinal immobilization, I don't know if you guys have heard this, but it has officially been replaced with spinal motion restriction. Now I know we might look at that and go, well, come on, we're just splitting hairs here, but there really are some significant differences, and this is national standard. Came out just this past year. Published in a position statement, a joint position statement by the NAEMSP and some other organizations there as well. And these are the people that, frankly, they're the ones that decide what the national standard is. So a couple of things about spinal motion restriction that are different is this right here. It recognizes that you can use other devices besides a backboard to accomplish this, including just the ambulance cot. Stretcher alone is sufficient. So because of this, spinal motion restriction can cause a lot less pain for patients. Now, why is that important? What happens when someone is uncomfortable because of being strapped down to a backboard? What do they start to do? They get agitated, they get restless, they wiggle, they try to reposition themselves, get off the pressure points. They start moving. That's kind of what we're trying to prevent. What's another thing that pain can end up causing? What about this? What happens when they get to the ER? When the doctors go to assess to determine what the chances are that spinal injury might be present and make the determination whether or not they need to send them in radiology, one of the things they look for is neck and back pain. Guess what a backboard does? It gives a patient that didn't have neck and back pain, and the doctor can't rule out the possibility of spinal injury, so off to radiology they go. And pain can also mask other symptoms. So there's just a number of things that are less than desirable there. So with spinal motion restriction, for transporting patients, just use this. Forget about transporting people on the backboard. There is no benefit to transporting people on a backboard. None. No proven benefit. There's less motion of the spine in patients that are just placed on the ambulance stretcher and coached to remain still. A related thing here is extrication. So we've got our traditional means of extricating patients from vehicles, and one of which is the KED here. Now, some of you have just started having palpitations. But let's talk about the KED and extrication for just a moment. Have you ever been in the middle of putting a KED on a patient and thought to yourself, there is no way that we're not manipulating the patient's spine right now? Be honest, okay? Everybody's thought about this? Yeah. Well, it turns out you were right. Look at this. Allowing a conscious patient to self-extricate causes less movement of the spine than the KED or traditional extrication methods, like dragging them out on a backboard. It's actually safer for them. Now, that being said, if you have to use the backboard to get them out because they are not ambulatory or they're altered, whatever the case may be, you can use the board to get them out if you have to. Just get rid of the board once you get the patient on the stretcher. Don't transport them on the board unless you absolutely have to. For those of you who are scared of giving up the backboard, I got good news. It still has a place. Moving the patient from point A to point B being the stretcher. You got a patient that has already gotten out of the vehicle and he's laying on the ground. You can use the board to get him up off the ground and move him over to the stretcher. But that's not the only option that we have. We also have these other options. The scoop stretcher being one of them. So, why do I like the scoop stretcher over the backboard? Well, one big reason is this. You don't have to log roll the patient. They did a study not all that long ago that looked at the log roll and found that it causes more motion of the spine, more shifting of the spine, than just a lift technique using the scoop stretcher. So you can say farewell to the log roll. That's some of the differences with spinal motion restriction. There's a whole host of other ones, but I want to move on here and talk about spinal clearance protocols. Now, some of you said that you have these, right? Show of hands again, who all have these? Okay, not quite half of the room. The clearance protocols were used in the hospital since the early 1990s. Physicians wanted to eliminate the number of patients being unnecessarily exposed to radiation by X-ray or CT. But this was not like a big secret being kept from us, okay? Because in 1990, the American Academy of Orthopedic Surgeons, the AAOS, that you've probably seen those letters on some textbooks before, right? Yeah. They told us right here, patients with a positive mechanism of injury without signs and symptoms and with normal pain response may be treated without full spinal immobilization, even with a positive MOI. 1990. Now, how many of you knew this? Does this surprise anyone? It did me. We were told that we could do this, but almost no one did until recently. The argument that people have against using clearance protocols is, are we setting ourselves up for litigation here? So I want to talk about one of these protocols, because we don't have time to cover them all, but there's one that's been around a significantly long time, actually since around 1989, 1990, right in that area, and has been validated over and over and over again in studies to be between 99% and 100% sensitive. That's the Nexus protocol. It says that we can consider clearing the spine as long as none of these things are present in the patient. Focal neurologic deficits, so they're not complaining of numbness, tingling, paresthesia, that sort of thing, and obviously no paralysis. They don't complain of midline spinal tenderness. Their level of consciousness is normal, okay? It doesn't necessarily mean A&O times 4, but normal for that patient. And there's no intoxication, and they don't have a distracting injury. My one criticism is this: distracting injury, we can sit here and think about it kind of like, I can't define it, but I know it when I see it. The issue is, they've done some research on this as well and found that the agreement between two different healthcare professionals as to what constitutes a distracting injury isn't all that consistent. So there's a little bit of an issue there, but maybe that'll be worked out in time. Even yet, this has a very, very good success rate. To prove this, this was one of the earliest studies conducted on the Nexus to put it really to the test. So what they did was they took over 34,000 patients that had been sent to radiography for suspected spinal trauma. They had that positive MOI. And out of that number, they found 818 with confirmed C-spine fractures. Out of that 818, the Nexus criteria found all but 8. And out of those 8, only 1 ended up needing surgery. It's arguable that immobilization wouldn't have done them any good anyway. We've got some pretty significant changes that are happening here. And by the way, everything that I've talked to you guys about this morning is in writing in that position paper that I told you about. And if you want to be able to get a hold of it, I can email that to you. It's readily available, but this is the article up there in the top left-hand corner. And these are excerpts from it. So this is not fringe science. This is actually the standard. There's a fear of this kind of change, fear of the litigation, and you know, that's natural, that's understandable. So another question is, what next? One of the changes that might be coming down may blow you away. This has not happened yet. We may very well be harming patients with the use of the C-collar. But have you ever seen a patient that was this happy to have a C-collar on? I love that. Right now there's a huge debate as to whether or not it's doing more harm than good. What kind of things can you guys think of? What have we always known about C-collars? What kind of harmful effects can it have? What's that? They never fit right. Okay. What else? Okay, yeah. Yes, it does have some negative effects on airway control being one of them. What else? You guys heard this one? Increasing intracranial pressure? Yeah, that one's been known for quite some time. Another thing that callers do is they can potentially hide areas, signs of life-threatening injury that you wouldn't otherwise see if this collar is in place, like swelling and expanding hematoma, tracheal deviation. It's a lot harder to identify. And because collars cause pain, C-collars may lead to undesirable movement of the head to relieve the pressure. And here's another potential problem, though. I find this one particularly fascinating. Look at this picture here. Now this is a cadaver, okay? This person's not alive, thankfully. By cutting some various parts within the spine, we're trying to simulate a severely unstable cervical injury. And this was just one of a few studies like it, where they applied the collar supposedly according to the manufacturer's instructions. And what they found was that in every single case, there was abnormal distraction, pulling apart a vertebrae, which would further injury in a patient like this. In one case, it was as much as 11 millimeters. So that's a pretty significant problem. Now, don't misunderstand me. I am not saying that you go ahead and toss the no-necks out in the trash as soon as you get back to quarters. All right? I'm not saying that. They are still considered the standard of care, but don't be surprised if that changes in the near future. For now, the takeaway point with this is that C-collars, like backboards, are not benign. Okay? They can and do cause serious harm if used improperly. Not every patient is a no-neck, contrary to what a number of us believe. One study took a whole bunch of EMTs and paramedics and asked them to apply a C-collar to a simulated patient. And it didn't matter the level of experience that the providers had. It didn't matter how confident they were in their skills. What percentage of those people do you think applied the collar correctly? It was a little more optimistic than what? 11%. 11% did it correctly. The rest of the time, there were problems with the correct measurement, correct application, and all kinds of other things that would potentially cause spinal injury. To date, there is no human patient study that's demonstrated clear benefit from the C-collar. There's nothing wrong with being skeptical when it comes to new things that challenge your current beliefs. It's okay to have doubts. It's okay to have questions. Now, we shouldn't be stubborn, but neither should we substitute someone else's judgment for our own. So don't just take my word for it. Don't take anyone else's word for it. When someone makes a claim and you're not readily convinced, go ahead and question it, but don't stop there. Answer the question. Okay? It doesn't make you a cynic. It makes you a good clinician. Trust but verify. Thank you very much.